Good evening, it's 8 o'clock and welcome to the 51st episode of Marvelous Medicine. I have the privilege of introducing Professor Vikram Kate. He is the Professor of General and Gastrointestinal Surgery at GIPMA Pondicherry. He did his MBBS and MS Surgery from Nagpur University and is a Fellow of the Royal College of Surgeons of England, Edinburgh and Glasgow. He's also done his PhD in Surgical Gastroenterology and several other qualifications are there to his credit. He is the past president of the Indian Association of Surgical Gastroenterology and has delivered several national orations and has been presented with numerous awards. He has more than 150 publications in national and international journals and is the author of 45 book chapters. He is the editor-in-chief of the International Journal of Advanced Medical and Health Research and is on the editorial board of the Indian Journal of Surgery and Gastroenterology Research and Practice. He has written 2 books, one on writing and publishing a scientific research paper, and the other on thesis writing for master's and PhD program. Thank you, Dr. Kate, for readily accepting my invitation to give this talk.
Pleasure.
Moderating the session will be Dr. Murli Chakravarti. He is the director of the anesthesia department and also the director of clinical affairs at Fortis Hospital, BG Road, Bangalore. Dr. Murli did his MBBS and MD anesthesia from Mysore University. He is the author of 178 scientific papers, 9 textbook chapters, and is also the past president of IACTA. He was the editor-in-chief of Annals of Cardiac Anesthesia and is currently on the editorial board of the Red Journal, Annals, JOACP, IJA, SJA, and TJA. Dr. Murli's special interests are cardiac anesthesia and infection control, and he spearheads the antibiotic stewardship in our organization. Welcome, Dr. Murli, and thank you for readily accepting my invitation. Over to you, Dr. Vikram Kate.
Thank you very much. At the outset, I would like to thank Dr. Vidya for thinking of me to join into the special session of Marvelous Medicine. And as you all know, recently it has completed 50 programs, and it's a pleasure and privilege to be a part of this program, always. And I'd also like to thank I'm a close associate of Learning General Surgery Group by Dr. N.Ananthakrishnan, and I've delivered some of the talks earlier in this group. And it's a big pleasure to actually share some of experience on writing a scientific research paper through this forum today. So I'll just share my slides. I think it should be visible. Is it visible? Slides?
Yes.
Am I audible clearly? Yeah.
Yes.
Thank you very much. So today, little bit we'll just share initially some talks I've given on writing a scientific research paper. So today I added some component of little bit about, in addition to writing, the end point of writing is ultimately publishing in a journal. So when we come to a work as such, we can divide into 3 aspects, broad aspects. Clinical, which practically everybody carries out if you are in any of the clinical specialties of medicine. Then academic, of course, now practically everybody is affiliated to some sort of teaching hospitals or teaching programs like National Board of Examinations. Some way academic also comes into the picture. It is also a part and parcel of our daily activity and work. The third thing is plus minus, the research, because whatever is said, even though for promotions in many setups, publications are required, some of the guidelines are there, but in spite of that, somehow research is relegated to the third position, and partly it might be because it might not be considered compulsory in many of the aspects of work. When it comes to the postgraduates, residents, on cartoon I have put, you see, so many other things are there on mine apart from their busy residency schedule. So again, there sometimes research takes a backseat. Now, sometimes I've heard people talking in conferences that we have got this series, we have got 100 patients of this, 200 patients of this, we are collecting the data for 5 years, 7 years, 10 years. But unfortunately, the thing is, if it is not published, it is like carrying the data, or you can say, even if you have done worked on the data and carried out some research, This is the aphorism describes that research not published, research not done. So it's extremely important that whatever is there with us, it should be published. And that is the policy we carried out, because I feel personally that especially in university or NBA affiliated hospitals, lot of research is done at the residency level in the form of a thesis. So whether it's a postgraduate thesis, whether it's a thesis at MSc level, or it's a thesis of DMMC level. So it's usually 18 months to 2 years work. And I feel that's a substantial work. And even if we continuously, rigorously publish those sort of research, we can really have an extensive research volume only based on that. Even if people say that apart from the conventional schedule, they are not able to take out time for the extra research work that is outside the purview. So I feel that 80-90% of the volume of research can come from the untapped potential. So once we go into that, it's a benefit for the student as well as benefit for the guide. Now, if you look at this publication, it's a small letter to editor published in Lancet. I said ordinary publication because it's just a half-page letter. Unidentified curved bacilli in the stomach of patients with gastritis and peptic ulceration. A young medicine registrar, Barry Marshall, he thought that some bacilli is there, they can exist in the stomach, because people thought that at that point of time, because of the presence of acid in the stomach, it is difficult for the bacteria to survive there. He said this could be the cause of gastritis and peptic ulcer. He collaborated with Robert Warren, senior pathologist in the Perth Hospital, Australia. And ultimately, they somehow sustained the research and identified and demonstrated bacilli in the stomach on the culture peptide dish. And this is how they published half-page report. Of course, later on, they published lots of articles on this. Actually, Barry Marshall had to temporarily shift to States also a few years and convince the people that what they were saying, the cause of peptic ulcer is actually a bacterial infection. And see, 25 years later, what they got? They were rewarded with a Nobel Prize in 2005 for changing the thought process of thinking what is the cause of peptic ulcer. So what started as a half-page letter to editor culminated in a Nobel Prize. When we do research, sometimes people say that, is it original work? Has it not been published? Will it change practice? According to our experience, that doesn't happen that often. You see, seminal papers, what they defined that change practice, it will change the thought process of people, what we also call it as landmark paper. At least based on our experience, we can say that not too many of those things will come. But that does not mean that if you have some original idea, you should not pursue. If you look at this research, role of H. pylori perforate duodenal ulcers were published in Annals of Surgery, at the time that was a leading journal in surgery. So 2000, they published that H. pylori infection, if it is eradicated, the recurrence of ulceration following the surgical procedure comes down drastically. So this was published by NG et al. In Annals of Surgery in 2000. This 1 year later, actually, we published a study in British Journal of Surgery. We studied more patients, 2002, and we had a retrospective and a prospective arm. And we also found a similar type of thing, that patients who had persistent infection had H. pylori infection. So practically these two things, that was, I think, from Singapore, and this study we carried out in India. Parallel studies were going on, and they published 1 year earlier than us. And ultimately, as I said, it gets rewarded. This was classified a paper in landmark paper, Journal Surgery, in one of the books, and in Indian literature also, you can see that it was quoted in the top 100 papers. A few years later, you can say 15 years later, we published this article, Adapted ERAS Pathway with Standard Care Patient Perforated Duodenal Ulcer Randomized Control Trial. Now, incidentally, this was one of its first study in the world literature, which had a large number of patients. We studied 100 patients, and this is how it gets awarded. This is the biggest conference of GI in the world. It was accepted into lecture presentation in presidential plenary. And this is the ERAS Society on which we did research. For the top 6 papers in the world, they have the best abstract finalists. It was actually included in that. So that's why I said these papers come far and few. And as I said, further reward for that paper was, this is the only meta-analysis on emergency ERAS which is there. And you can see all the other studies from other countries. This is the only study from India which has been included. So as everybody knows that that Osventer is very well known for corrosive strictures. So you can see this 109 patients, one of the largest series in the world on chronic corrosive injuries of stomach. Again, as I said, it established a classification and it established a treatment. And similarly, the procedure on coloplasty. So do we mean to say that we should always target and go towards landmark articles, go towards the research? No, if you see that, except the first one, a lot of other articles of ours also have got reasonably good citation. It indicates that overall landmark papers will be few, but good research output always contributes to literature, always. So the target should be keep on persistent. It's like you cannot think on in January, I will think of a concept, and March, I will bring out I will do the research, and July, the research will be published. That sort of thing doesn't happen. And you should not wait for one research to get completed to start another one. It's like a conveyor belt. You have to continuously keep on doing research, and the output keeps on actually getting produced out from a like a factory. So what are the different types of scientific papers? Basically, if you see the right side, these are the original articles. What we call is that case control cohort studies, cross-sectional case series, systematic and meta-analysis. The left side, invited reviews and case reports. So these are different types of scientific paper articles which we see. When I tell my students, they ask like, how do we start? What should be the aim? So I usually tell them that initially when you join as a postgraduate in any stream, in any specialty, there's no harm in starting with case reports. A lot of people actually, they will rubbish off case reports. What is there? Nobody reads. It will not impact. It will not have some citation index and all those things. But I feel that to learn the art of writing, case report has only three components: introduction, the case summary, which is there in the discharge summary or the case sheet, and you write about 2 paragraphs of discussion, 5-6 references, and the report is ready. Once you get stimulated into something, you cannot straightway start with a randomized control. That might be difficult. You might be doing an RCT as a thesis, but why write a endpoint of a thesis after 3 years of your post-graduation or a specialty or subspecialty? You can start when you have joined. Case reports you start, case series slowly, make 2-3 case reports, and then join in, go into the conference, present, and get exposure, listen to others. One of the best ways of learning is to listen to all around, listen to others. So that's how it is, you have to go. And this is what I tell my students, that when you write an original article, let's come to original writing, if you write it almost fully under supervision, obviously, I feel that 60 to 70% of the art of writing you gain into the first paper itself. It has to be written fully. It might take few weeks, few months also to write, but you can gain 60 to 70%. Second article will again give you 10-15%. If you write 3 original articles completely, of course, under supervision, completely, like right from the first page, that is the title page, right up to the last figures or tables, whatever you're putting there, I feel that 90% of art of writing you gain it. After that, it is minimal only, whether you write 5 papers, 10 to 15 papers. Of course, experience always keeps on increasing. But a good amount of this thing, it's not that you have to publish 25 papers, 50 papers to become good original article. 3 to 4 good original articles, quite a lot, actually, you can learn it. So what are the do's of writing a good manuscript? You have to look at the instructional authors, check the word count, formatting, number of figures and tables, reference styling, citations, and etc. So if you see Annals of Surgery, as I said, it's one of the leading journals in the world right now. They ask only for 3 authors. Most of the other Vancouver styles will ask for 6 authors minimum. I mean, minimum in the sense, like after 6, you put the at all if you have more than that. So what I'm trying to say is that what we usually do is we prepare a master manuscript. Master manuscript will be that is usually common to 80 to 90% journals. And from that, you start modifying the manuscript, which is pertaining to a journal. So that if for annals you have made 6 references to 3, next journal will say, no, you have to put 6. Again, you cannot go on searching for the references. That is what I just wanted to highlight. This is what we usually follow. And this is what we have written in the chapter. This is a surgical gastroenterology book in which we have written how to write and publish a paper. You can see there, first we usually concentrate figures and tables, so that will give us the data. Then the methodology. Methodology comes from the protocol, you have to expand it. Then the results, a brief description of the figures and tables. And then the most difficult part of the paper, that is the discussion. So once you have written the discussion, then of course we write the introduction to. Introduction as is like an opening of the door. It's like as I said, it's like something like a invite, the face of the paper, that why you should do this study, please come and read the paper. So that is how it is. So that has to be written last. Now, of course, the conclusion. Once you have done that, the condensed version of the paper, what we call it is an abstract. and then reorder into the eminent format. Of course, this is not the standard order for journals, it's the eminent format. We just reorder it. What usually we feel that, you see, when you have a good content means, as I said, if you take that first article on H. pylori, practically nobody much knew about the role of H. pylori in complicated duodenal ulcers, especially perforation. Content was so new that any journal would have sent. British Journal of Surgery, of course, is one of the leading journals, but any journal would have said it's very difficult for them to refuse because of the content. Your style, if it is plus minus, they will tell us, please write it properly. Even if there's a deficiency in English, please correct it. But nobody wants to leave a good content. It has to come to the journal. If the content is average and the style is average chance of publication. If the content is poor, a repeated study, nobody's interested in that sort of thing, something obsolete you're putting. Even if your style, English, everything is good and you have taken the help of a master writer and everything manuscript is good, it can get rejected in first shot. So that is how overall you have to see. So this is the time to get a good content. The protocol stage itself, you have to think of an idea which is good and which will later on come into a, not only go into a good publication, but it will go into a good high impact journal publication. This is contents of manuscript. Just to complete the list, abstract, keyword, stars, you have the title page here, and then you have the introduction, the Brad, okay, what we say, and then references, table, figure. This is how the standard sequence that is usually accepted in most of the journals. So we have to write a manuscript, each part accordingly we have to prepare. So this is the title page, a standard title page. Okay, it varies according to different journal to journal. Some journals will ask the qualification. Some journals will ask the email address to be put here beneath. So many little minor variations, and then you'll see the instruction to the authors for that. And of course, this is the standard way. Put all the authors, and then in Annals of Surgery, if you have more than 8 authors, you have to justify. They're not restrict. Some journals restrict the authors, especially for case reports. So then you have to decide while planning stage how to put them. Then address for correspondent. Nowadays, many journals are asking this author contribution right in the title page. And then they will have the standard format which you have to follow and appropriately credit each author with whatever they have contributed. Then comes the abstract. Okay, though an abstract is the first thing reader sees, it's the last thing the author writes. Obviously, it's a condensation of paper, so unless and until the paper is ready, you cannot write the abstract. It is a standalone statement. Although abstract is a part of the manuscript, it is a completely standalone statement, and by the reading of the abstract should never ever be connected to the manuscript. If you read the abstract, you should be able to completely get the gist of the paper. That is how it is. That is very, very important. Provides an overview. An effective abstract encapsulates the essence of the article, gives all essential information about this. Every essential information is given. So what are the important points? What is the importance of the abstract? You can see here. Only part available in PubMed if the journal is not freely available. First scrutinized by potential readers, and they may go forward to buy the paper, or they might go forward to read the paper, retrieve the paper somehow and read it. If the abstract is properly written and you have substantial data in the results, although it is advisable to see the full paper, many of them might actually cite the paper based on the abstract findings. That is why the results has to be very carefully written in the abstract. It should have all the important figures, p-values, everything. So sometimes, as I said, sometimes I should not say, nowadays access of full articles has become easier, but many times, you see, the citations would belong only in the abstract. Used to invite potential referees. Many journals actually, when they invite, they will send the abstract. If you're interested, please tell us, then we'll send the full manuscript. Otherwise, there itself you can refuse it. Conference abstract slightly different from that, but conference abstract, obviously the many journals, okay, many conferences, they categorize the paper according to the abstract. Very few, even the digestive disease week, the whole categorization happens on the basis of abstract. So it has to be written carefully, and they give little advantages in the abstract. They will allow you to publish one table and figure. So it's a little extended sort of abstract, but definitely the abstract only is the basis for the paper. I'll tell a little later what is the advantage of those big conferences. And as I said, many times when you bring out the proceedings, the Digestive Disease Week comes out in the journal Gastroenterology. That's the leading journal in the world with an impact factor of close to 20. So all the abstracts get published there as a part of if somebody presents in DW. Okay, so that is what happens. So that's the advantage of writing a good abstract. Now coming to the main content of the paper. Title page is over, abstract is over. You come to the introduction, methods, results, and discussion. Because title page is a separate page, abstract is also a separate page. After abstract has not covered the keywords, so the important words to actually get it, so that you can actually use the mesh also to get the keywords so as to retrieve the article when you actually getting it from search engines. Now, IMRAD, introduction, methods, results, and discussion. So here it is like a wine glass or hourglass model. So what you can see here, introduction is always broad, always broad. Why you're doing this study, everything you risk it. Methods and results are a little narrow, pertaining to that study. Pertaining, it follows a little reasonably rigid pattern. And then again, it becomes broad in the form of discussion. That is why the pattern is called the hourglass or wine glass model. So when we write introduction, methods, results, and discussion, if you remember these 4 questions, an answer to these 4 questions, usually the manuscript will come out well. Why did you start? What did you do? What did you find? What does it mean? Discussion. Results, what did you find? So this is what is, these are Bradford Hills questions. If it is answered, you can have a very good IMRAD written, the manuscript written. That's the core of the manuscript. So if that is written well, so the likely endpoint of the manuscript is likely to be good. So introduction, rationale, it's like selling the paper. Specifies the reasons for conducting the research in the light of current knowledge. And we can say usually it should start in a funnel shape. Broadly, which phenomenon you're studying, then go to a little narrow phenomenon, and then the narrowest part of the research question. Now, if you see here, this is an adapted ERAS pathway versus standard care in patients with perforated duodenal ulcer, randomized control. So ERAS pathway in emergency. So this is what it is. The ERAS is the broad thing. Since it is done in emergency, it has become a little narrower. And the specific research question here is, what is the role of ERAS in patients with an emergency, that is perforated duodenal ulcer? So that is how it goes. That is why we call it funnel shape. If you take it properly funnel shape, it should read well, sound well, and it should be very interesting to the people's reviewers, because when they give clearance only, it becomes an article for readers. Again, so with another example, efficacy of single layer and versus double layer. So you can see here, although evidence is that single layer is safe and all those things, okay, but a lot of people are not practicing. So you're making readers avid that why the study is being done. If they are not interested in introductions, very likely they will have an impression on methodology, because if they feel the study should not have been done in the first place, what's the point in actually reading the methods and results and all and getting impressed with? That's why they said this is the face. If the face is shown properly, they're interested, then they might go a little further. When it comes to the aims and objectives of a paper or even randomized control, the title of the paper, usually the PICO should be there. Patient population should be mentioned. What is an intervention? What is the control? And what is the outcome? So if you look here, title may or may not have everything, but the objective should have. I put in different colors to look it simple. There are 2 papers. So this is in green is the patient population. In blue, it is the intervention. Intervention is RAS. The standard care is this thing. The standard care is the control. And the outcome I have given in red: safety, efficacy, and feasibility. So that's what is important. So we come to the most important section, which actually reviewers will focus, read, and they might reject basis on the basis of this. This is very, very important section of the manuscript, according to me. And the scientific integrity of the study and the credibility of the study depends substantially on this study and the study design and methodology. So if you look at this particular photograph, this photograph has a lot of importance in all the important newspaper publishing offices in the world. What is the speciality about this photograph? Who's holding the photograph? Why is he holding? And what is the significance of this particular headline? This is what it says, that DV defeats Truman was an incorrect banner headline on the front page of Chicago Daily Tribune. Later it became Chicago Tribune. 1948. This is considered one of the greatest mistakes in the banner headline. And you can see the person who's holding it is none other than the next president who won for the second time, Harry Truman. And what I read a little bit about it, the paper did not like him much, and he also did not like the paper. He is showing it there. This is the origin of the paper. So they wanted to bring this little earlier, so they published it at I think 3 o'clock or 4 o'clock in the morning, thinking that it'll have a great sale, and almost it was certain that DV will defeat Truman. But ultimately it changed and Truman defeated him. But once the paper is released, newspaper is something, once it is gone into the market, you cannot get it back. So why I given this example is, this is what is like that. Methods I put in different color. If you look here, this is the irreversible part of the manuscript. Why it is an irreversible part of the manuscript? Because it is the core component of the study. See, if the reviewer says, please change the reference style, you can change it. Reviewer says, please modify the introduction, add this to references, you can add it. Reviewer says the tables, make it figures, figures, make it tables, write the results like this, you can make it. It will take only 3 days to write that. Discussion, maybe 8 days to write. Reviewer says the methodology is flawed, it is not correct, please redo it. If your study is of 2 years, you need another 2 years to do the study. That is the problem of the methods. So all these things can be corrected in 8 days, 10 days, 15 days, maximum maybe 3 weeks. If you want really little more results and all recalculation, do that 3-4 weeks. But this will take you back absolutely. If the major flaws in the results, methods, it's gone. So that is why it's extremely important that when you start the study, you should be very sure that the methods are sound. They're absolutely sound for that particular type of research. So reviewers also mostly target the methodology in the review section. So what we usually advise is that it can be put into these different sections. And if you put into different sections, usually you'll write it properly, substantially. Of course, the methodology has to be decided in the protocol stage, but when you're writing the manuscript, it is written well. So it's like that. This is a recently published article. You can see study design. All these things are given here, how it has to be done and all that. And this is another paper which I'm repeatedly quoting for continuity. And then registration of the trial, see the number and all is given. It's become mandatory for randomized control trials. Now other types of studies also is required. So it is better to be put in the manuscript. This is the different headings under which we usually include our methods. The aims of the study and short objectives will always come at the end of the introduction. Somebody says that where do you look for aims and objectives? They say that at the end of introduction, you see 2-3 lines of aims and objectives. The details of aims and objectives are usually categorized under outcome measures in the methodology section. You can see here the primary outcome, secondary outcome, all those things are mentioned. This is the key for methods, that you must, whatever methodology you do, whatever method you use, support it with standard references from standard journals. The reason is that when the reviewer questions a particular methodology, this reference will talk to the reviewer. That's all. You don't have to do anything. You say that this was carried out according to this publisher. It has to be a standard journal. Once you send that, most of the editors will actually accept it. Even if the reviewer is not very much in favor of that thing, editor will overrule. And what you will find is that you have a good chance of. See how many, I always tell them that good original article, nothing less than 10-12 references should be there in the methodology. Remember, result section, there's no references are there. So it is studied with references. You can see that every practical thing is actually quoted, and it is based on a reference. That means it has been published in a peer-reviewed journal and accepted method for that particular study. Sample size, a lot of people ask questions about this. And as I said, if you don't, we can't go into details of that, but sample size calculation, the protocols should be carried out. So they don't carry out, they don't commit as type 1 or type 2 error. So that is what is important, because when you do good research, novelty, everything is important. But if it is underpowered study, you will not get the results. And if if the study has low sample size, you can sometimes rarely actually make a false positive also claim. So those things are not good. So this is how we mention the sample size. Sample size is always targeted with the primary outcome. Always. If you have 4-5 outcomes, one primary and 4-5 secondary. Secondary outcome usually we don't target for because that's not your primary outcome, primary aim of the study. So we leave it at that. But all the primary outcomes have to be targeted and the sample size has to be calculated. You usually have articles will have mostly one primary outcome. But if they have more than one primary outcome, the largest sample size for each primary outcome becomes the sample size for that particular research. So that's very important. This is how we mention it, the sample size. Always base it on the effect size and all that has to be controlled, what you are interested in the clinician, and take previous articles references. That is a must. You can see here also references quoted. Always better. Always you're on stronger grounds. If you do not have a previous article, then you might have to do something called as interim analysis and then actually progress further. This is all about sample size, how you have written there. And this is sometimes what happens is you target a sample size in this particular patient. You can see that you're little short on 100 was the thing 94. See, the reviewer actually commented that is the study end up out. Then we had to give a good justification here we are given. And that is the reason we stopped. That is the reason it is less. And of course, then it was accepted. Now we come to another important section of the manuscript, the results section. It is the highlight of the manuscript. It is the most unique part of the study, most unique. Because when anybody does a research and people want to know what did you find, they will not be able to get that information anywhere in the world except that manuscript. See, if you read the methodology, many of the methods or the procedures that you have followed out in the research might have been taken from other published articles, which you have carried and tailored. That's why I said so many references. But this is extremely unique to the particular study. And then you can put it, you have to write the results, and then of course you can put in table format, figure format, and all that. So that's a standard way to put it, and these are what. So these are a few tips for writing results. Should definitely not be confused with discussion or conclusion. It's totally different. In results, we don't write that we have found no reasoning and all, absolutely, only facts alone. No references unless sometimes it is systematic view and meta-analysis. Provide all numbers, p-values. Here, that's why I said these things will also go into the abstract. It should be richly provided with all. You don't put only percentages. So you have to put the actual numbers also. Percentage sometimes can be falsely leading. Okay, so avoid duplication data because you see the publishing space is at the premium. So if you have put the details in the table, there is no need to repeat it. Only the just important points you mention. Be specific and show the implications and relevance straightforward, not indirectly. And if there are negative findings, clearly put it. Let the reader make an independent judgment from the results. You don't try to put any words into or any thoughts in anybody's mind. That is extremely important in results. That's why I said we never give any reasoning and all that. What we found from the study, put it under the section. Usually results will not be a very big section because most of the results are depicted in tables and figures. Then comes the most difficult part, according to us, writing manuscript. The discussion. This is the format we have devised and we follow. Because if you have a little pre-formatted type of discussion, it really goes on well. Most of the good journals, if you see, usually it will run on this part. Summary of the results, one para will be there. Preceding section only is results, but you have to give a gist of summary. Knowledge gap, how your study has actually improvised the knowledge into the literature. Compare with other studies, results similar, dissimilar, give reasons. Limitations and strengths, always you have to put. If you identify your own limitations before the reviewer, you outsmarted the reviewer. And then the conclusion. So you can see here. Here we wanted to find out where ADAS pathway is useful in perfect diagnosis. If you see these 4 lines, the whole answer to this manuscript is written there. So that is the gist, the first part. Then the reasoning, why this study was done. The previous studies, this was there. In the present study, how it actually outsmarts the previous study. And then how it, of course, compare with other studies, limitations and conclusions. This is what should come. Same thing here. It's always on the similar lines. That's what we have done. All these papers, you can see they were all accepted in the SSAT plenary presentation. This one. You can see that all they are there. And that's, as I said, that's the Surgical Gastroenterology Association of the US and one of the largest GI surgery associations in the world. What is written in the conclusion? The answer to the objectives. You can see here, that's why I put the objectives on the top. And exactly the answer to that is the conclusion. Objective of the study was to evaluate the feasibility and efficacy and all those things. And here you can see it is modified, feasible and safe. That is what it is. Of course, you have to give answers to the objectives. Primary objective, second. The primary objective was length of hospitalization in this study. We have written there what happens to that. And some secondary objectives, important ones. What is there? Early functional recovery, reduce post-op mobility. The secondary objective. That's how it comes to conclusion. This is a systematic review, slightly different, okay, from the original article. But again here, objective is this: evidence of the efficacy, adverse effects, costs. Two regimes of H. pylori are compared. See, the answer is there. It has got good efficacy, cheaper alternative, no increase in the adverse effect. So everything what you asked in the objectives, the replies are available in the conclusion. If you write papers in a focused area, become little specialist, that you see, this is the first, one of the largest consensus statement made for H. pylori infection in India from the Indian Society of Gastroenterology. And it's a pleasure, it was a pleasure and a privilege to be a part of this particular group. This is just now published in 2021. It's in the that ePubmed stage only right now. It has not got published in journal. And as I said, I'm proud to be a surgeon and a part of this. All these are gastroenterologists, microbiologists, non-surgical people. But since you have done some work on H. pylori, so I was invited for this group and this consensus statement. This is one of the largest consensus statement on H. pylori which has come out from a country. Should be very useful for everybody. And I'm not going into details of that. This is how usually the consensus statements are made, that you have levels of evidence and then recommendation from the expert group. And accordingly, we'll put it level of evidence, grade of recommendation, and then of course the presentation goes on. But this was my first experience to be a part of a task force group, and it was a good learning experience. Always everything is a good learning experience. As I feel that the scientific writing, research, everything is always learned by being a part of something. That's one of the best ways. Now, many of my postgraduates will tell, sir, our study is negative. What happened is, sir, they don't understand that whether positive or negative, the study contributes to the literature, always contributes to the literature. If you put a negative study, and some more negative studies also have found out that the same finding, at least people will stop comparing whatever you have done. That is the advantage of this. So a negative study should not go into the drawer and then the drawer should be closed. That is what is called a file drawer problem. Because if that is done, then it can lead to something called as publication bias. So with the funnel plot, it will show like this. Just give an example. If like you want to see a new intervention is A, compare it with B, and we want to see whether A is better than B, and A is the new one, B is the existing one. You have done 10 studies, and in 10 studies, we have found in 4 studies that A is better than B. 6 studies have shown B is better than A. 6 studies have shown the existing treatment is better than the new treatment. But because your primary aim was to find out or practically prove that A is better than B, it becomes a negative study. And because it is a negative study, let's say 5 studies are not published, they are not sent to the journal and they are put in the drawer. So what will be the final result? Out of 5, 4 have said A is better than B, and one is only saying that B is better than A. So you will say that you will discard the B treatment regime and accept A and commit a type 1 error, false positive error. So that is why it is necessary that study is positive or negative, it should be sent for publication and should be published. And it's a negative thought to think that a negative study will not be published. And this is, just to give an example, see, this is a negative study. It was to find out the effect of perioperative high oxygen concentration on surgical site infection in patients undergoing elective. Again, it was selected in necessity plenary presentation, and it was published in the same journal of gastrointestinal surgery. So positive and negative should not make any difference if the study is properly conducted. Just few examples. This is 2021. Actually, fortunately, DDW declared before itself that it will be a virtual conference. So I actually encouraged my students to present directly, because otherwise US conference, you have to travel to US and it's not easy. You have to register and so many things. So if you're a candidate member of DDW, registration actually is complimentary. Candidate membership is only $20 per year. And see, so many of them actually presented. One of them in lecture presentation, one of them in poster of distinction. And this is again a lecture presentation. So it was a good opportunity to present from home directly into the largest GI conference in the world. And I'm proud to say that this is what is called as the SSAT Residents and Fellows Research Conference Presentation Awards. This they give to 3 people in a year, and last 14 or 15 years it's going on by the Society for Surgery of Alimentary Tract. This is the first time an Asian paper, I'm not talking for an Indian paper, Asian paper has been included in last 15 years for this. Otherwise, always American, little bit Canada, sometimes only Europe, sometimes only. Very difficult to get to compete with the North American continent. So I'm lucky, I'm proud that my student actually, in the top 3 it was there, and soon it should come into that website, and it is permanently there on the website. Once you send to this conference, the other advantages, they have this plenary session, what is labeled there. And there's a drop-down menu where you submit the manuscript for it. So if you select plenary, it goes into fast-track publication mode. And most of the time, it's like an invite for a reviewer. If you get an invite for a reviewer from a prestigious journal, very unlikely that that reviewer, that invite will be rejected, because they have invited you to write the particular, whatever you're writing on a particular topic. So high possibility is there of acceptance. The same thing is here. Once you put it in drop-down menu and you tell them in DDW or SSAT, it was presented in a SSAT plenary presentation, see the acceptance times for publication. 2 months it gets published. The official journal is Journal of Gastrointestinal Surgery. It's a very reputed journal, and you have a publication. That's the advantage of putting it into conferences. Not only that, then you can have the opportunity to present. So they invited me to present this thing, and it was in the webinar mode because, of course, as I said, because of COVID, many of the things. You can see the other people who are there. Cleveland Clinic, you have Mayo Clinic. Mayo Clinic is one of the leading centers in the world for last, I think, 25 years or something like that. Cleveland Clinic, everybody knows. And that is where Jupmak was placed. So that was a very proud moment for us. A little bit about after writing, we have to send it for publications. A few tips about that. Select the most appropriate journal. Increasing the likelihood of publication will depend very much upon that, very much upon that. And what is the way to select? See the references, your own references in the manuscript. So other people who have actually who have contributed on the same topic what you are actually doing the research. See which journals it has got published. So you get an idea of which journals you should send. As far as possible, if the quality of, not as far as possible, the quality of work is good, you must send it to a good journal. See, every work cannot be a top level work. So you have to decide your quality of work. You make with experience, you get a judgment, and then appropriately select a journal. If your quality of work is average and you send to a top ranking journal, almost 99% there's chance that it will get rejected, because the quality of reviewers there is different. That is how it gets linked. So that is why you should know where you stand for and then appropriately select. The aim is to actually have a good publication in the most appropriate journal for that particular research. That is very important. And of course, as I said, it goes without saying that if you publish in a good journal, it will have a lot of readability, wide access, and then citations. So all these things are there. Avoid predatory journals, prepare manuscripts. I already told earlier that you have to do. And these are the few checklists the journal itself gives. Now we have the big consort checklist for a randomized controlled trial and a PRISMA checklist for systematic review and meta-analysis. Those things can be followed. There's a STROP checklist for the observational studies. So all these things are followed. Once actually, as I said, it's like the conveyor belt. Once you go into the system, everybody follows it like an operation. You see, so it's like that. This is quite frequent. You may be a top researcher or you may not be a top researcher. Okay, everybody faces rejections of manuscripts. Everybody, as I said. So of course, we don't do this. That's a cartoon. So the key points to remember are not following the instruction to the authors. Should never be done. It's very silly that this will be called as a silly and stupid mistake. Should never be done. What is that? You just read the instructions, mark it. But nowadays, that yellow highlighter that I always tell the students, mark it off the important aspects. So even if there are 15 points given, we know when we are submitting those highlighted points you see, and make sure that everything is properly put in the manuscript. Important not to disagree. My favorite saying to my students is, reviewer is God, never antagonize, as far as possible. If they advise something which is going to bring down the quality of the manuscript, then of course, as far as possible, they are giving green light for publication in the journal. If it is possible and doable, always do it. Never forget to incorporate relevant responses to the reviewers in the manuscript. You see, some people only put it into the point-to-point reply. I will always tell them, if you put it in point-to-point reply, this is a good point they have told, it's not going to the manuscript. So what is it? The level of the manuscript still stays at the same level. So we should do it. Resubmission to the same journal, not advised. In general. Like you see that once they have rejected, sometimes now the journals are asking also, have you submitted this manuscript earlier to a journal? And if it is, what is the manuscript number? Preferably avoid. And of course, choosing the correct journal after. If it has been rejected, revise it and send to a journal. You should always select a journal at the highest impact factor for that research. Always. So it's like 4, you start with 4, rejection come to 3, rejection come to 2, like that, down, you should come. If you start with down, if you are sending it to 2 and the quality of the research is very good, it could have gone in 6. Now you have missed sending it to a journal with impact factors. That's how it is. See, now when we submitted to DDW those papers, SSAT, it is mandatory that you have to publish it in that journal of gastrointestinal. They say that if you are submitting here, please send it the full manuscript. And it is essential that if it gets selected in the plenary, it should come to a journal. That's the thing. If you do not submit there or some problem happens in presentation, that's a difficult. Otherwise, there's a good chance that you might select a journal with a more impact factor. But sometimes that becomes a restriction when you go through the conference mode. Advantages, you have a fast track publication. Disadvantages, that. Relevance of the topic is common rejection. You see common reasons for rejection. Unimportant topic, okay, research question. I said, this is at the protocol stage. If you select something which has already been established, meta-analysis are there, and now you're doing a randomized control on that, what's the point? For a study design, you want to prove something, okay, is better than that. The best design for that is, if it is feasible, is randomized control. If you have chosen some other design, it might not work. Improper manuscript writing, this comes with experience. Lack of interpretation, this is not concordant. Again, writing skill has to develop. Wrong journal, as I said earlier, non-compliance of the authors, instruction to authors. As I said, these things are basic things which should be done. Of course, this has to be very clear. With experience, it has to be done. And articles are rejected even before sending for a peer review. And for blacklisted authors, scientific misconduct. So this is a flow chart in short, like after peer review and comments and all that. This is how it goes. So not going into details on that. So is publishing enough? No. H-index attempts to measure both the productivity and citation impact of publication. So what is H-index basically? It is like if this is my H-index 25, so that indicates that I've got 25 papers with at least 25 citations. That is what it means by I-index is 10 citations, 65 papers with 10 citations. So writing and publishing a scientific paper becomes enjoyable when you split it into simpler sections and approach each section systematically. So this is how I started. Not that you have to start with big papers. Intention of surgery, case report, tuberculosis appendicitis preparation. Always indebted to sir. As I said, when I joined, nothing I knew about publication writing and all. So if I have got 150 publications, sir has got 450 publications. Always will remain my mentor. So these are the few publications. Many of them are RCTs in good journals in the last 1 year. Some recognitions and publications are very important for that they contribute to your recognitions. This is the research committee of this. So it's a privilege to be a part of that in 3 years. Surgical specialty boards of the Royal College and all. And of course, the reviewer. The reviewership actually increases your knowledge tremendously. These are the books what Dr. Vidya had mentioned. I'm lucky to be my research work is a lot of research is on H. pylori, and I incidentally met Barry Marshall, the Nobel laureate of this guy. Thank you very much for your kind attention. Very grateful again to Dr. Vidya and GS, Dr. Radhakrishnan, for giving me an opportunity to share some of experience through this medium. Thank you very much. Thank you.
Thank you, Dr. Vikram. Over to you, Dr. Murli.
Thank you, Madam. Professor Vikram, it was a very, very enlightening presentation.
Thank you very much. Thank you. Thank you very
I
much.
don't know whether I am empowered to make any comments at all. Of course, I cannot make any comments about your facts that you have put forth because they are so evidence-based. However, for the sake of the audience who may want to be starting writing, I have a few points to make, if you may permit, sir.
Sure, sure.
One is there are misconceptions among Indian authors saying that we are Indians, Westerners don't publish our work. I think Dr. Vikram's publication is a testimony that if the content is good, they themselves alter your faulty English and publish it. Please don't go away blaming the Western journals that they don't publish. It is because the content is not good. See, the letter to the editor got somebody a Nobel Prize. But I think it's a conviction that when you're starting to write a paper, it is likely to get rejected. It's very, very possible that it will get rejected. It need not be a path-breaking work that you are publishing. Path-breaking work comes after a few ordinary papers, case reports, and then letters to the editor. Never think that your first paper itself should be cited 2,000, 3,000 times. That is a very wrong expectation. And the thing, whatever study you do, please do not discard the original data. Actually, when I'm sure Dr. Vikram also started the work, it was all in paper. Now we have it on a computer. Those days, the papers, the master charts that we used to create, you have to keep them because some journals ask for the original data. And some of you in anesthesia may know that a gentleman from Germany was, discredited for the wrongdoing. A simple reason that he could not give the data. His work was wonderful and he could not give the data. The journal repeatedly asked for the original data. So all his articles were retrieved. Please do not discard the ethical clearance. Some journals want that it's up to the last stage of acceptance. They say, please send your ethical clearance. And I think the academic fraud that one may want to create or create a wrong data and call your paper a path-breaking is, in my view, a human crime. Because of your work, some child, some cancer patient, some cardiac patient may actually not make it. So please do not anytime put wrong data. I don't think the patients deserve that. And nowadays, if you want to publish a case report, most journals ask you for a patient consent. If you do not have the patient consent, even if you are not putting the patient's face or photo or name or whatever, you ought to have patient consent, explain to the patient the need for this publication and take a consent that he or she consents to your publication. And of course, I will put one of the questions was, should I publish in the same journal? Dr. Vikram has already answered. I think you should choose the horses for the courses. There's no point in publishing anesthesia-related journal article, say, for example, something like the complications of thoracic epidural anesthesia in a journal of forensic medicine. So it won't get published because there is one column for rejection. This article is unsuitable for this journal readership. So please do not do that. And many people say we use the SPSS software. SPSS software is a software which you buy. If you do not have your license, please do not put there. Because I have heard of cases where the editor has asked for the copy of the your own certificate of buying the SPSS. There are other software. Excel is a good software. There is a software called R, which is free on the internet. And EpiInfo is a good one. You can do that. And also, this is my personal view. When I publish, I always try to give some work to my students and tell them to, search for references or put the references in the Vancouver style and all that. Those are all learning and include them as a co-author. You saw Dr. Vikram's article. All the time I've been seeing Dr. Pankaj Kundra is his anesthesiologist. He is there in all the papers. So it really gives a good feeling to the entire team to be published, and you become one cohesive unit, and the research is so much more robust with so many people. And publish, perish, or if the research not published is research not done, was Dr. Vikram said. I will tell you one short story. Many of you anesthesiologists may know about Dr. Martin, who gave the first ether anesthesia, 16th of October, 175 years ago. He published it in the Boston Medical Journal a couple of days after administering anesthesia. And then came another gentleman called Prof. Long, who said, I've already administered ether. And the proof that he had was a receipt that he had given to the patient for administering ether. The medical journal said the proof of doing a thing in medical science is publication, not a receipt. Although there is a huge controversy among the anesthesia circles about Crawford Long and Morton. Finally, Morton became immortal because of his work, which was published immediately in the Boston Medical Journal. And many of you may be wondering whether you should go and publish in open access journal. You know, that's a hotly debated topic in the academia. So open access option is also available in good journals. These journals publish, but they do not make a compromise on the quality of the work. So your idea is not to get published, but get published in a journal which has an impact factor of more than 2. It is very difficult. But like Professor Vikram said, start at the topmost impact factor, and then you can climb down. I tell you, the publication makes you immortal. Nothing else does. Your newspaper article will be forgotten in 14 days. But your publication, even if you have done some kind of a work now, 100 years later, somebody may write history of anesthesia and your name will pop up there. So please do publish. And it's a very humbling self-learning experience. I have seen such good reviewers being so patient with your work and have written a 4-page review on your work. And every time you read that review, it is a learning for you. Even if they have rejected, don't feel bad. They have rejected based on the content, but they have given you tips how to write better, how to plan your work better. So publication, I think, is a must. Somebody said one of the things that doctors should do before they die is at least have one paper published in their name so that it is in black and white, and to see your own name in a black and white or in a reference list in a conference. They say our own Dr. Vikram has published this, the whole audience turn towards you. That is $1 million moment. Thank you, Vidya Madam, and thank you, Dr. Pata. And there are a few questions, I guess. I will take a decision about whether to read them. I'm not going to open the conference to the audience fully. Madam, is that okay?
Yeah, if while you're looking at the questions, if anyone has any question or comment which they want to make, Ravi, go ahead. You can unmute yourself.
Hi, Vidya. Thank you. Thank you for a wonderful presentation, sir.
Thank you.
I just wanted to sort of add a couple of things in terms of how to foster publication in residents, junior faculty, etc. And I think one of the biggest resources that is not properly exploited is the amount of clinical material that's available in India. I think something that a department, say in an institution like JIPMER, can do is to make sure that every patient that comes in is part of a database, to set it up in such a way that appropriate consent is obtained right from the very beginning when the patient comes in for clinical care, routine clinical care, and obviously have this approved by the IRB, etc. And then once you have that database set up, you can mine it, and that could be your how your residents and junior faculty start publications. Start mining the database, looking at different things, and that is something that I don't see people do, and I think it's I mean, to use your own words, a criminal waste, because there's so much experience and so much information that needs to be shared that is not being shared. So I think that's something simple that can be done from an institutional level to promote research and show commitment to helping trainees in their research journey. So that was my overall comment about the institution and how the institution can foster research. In terms of writing a manuscript, the one thing that I do believe makes a lot of difference and takes away a lot of these annoying administrative issues away from the person who's writing it is to have a publication department, or like a medical writer and a publication department that takes care of, are all the I's dotted and the T's crossed for this particular journal? Is everything that this journal asking for done in this paper? That's something that taking that out of your hands actually lightens the burden quite significantly when you're writing the paper. And I think the first step that needs to be made when you write a paper is to sit down and plan the manuscript as to exactly why are you writing this? What is the gap? What is this going to address? And immediately after that, to talk about who are the authors and the order of the authors. And this sort of helps because ultimately when you do your ICMJE contribution disclosure, it sort of helps to figure out who it is. And also if you send out, like as the lead author or the person who's coordinating it, if you send out emails to all the other authors that you want to invite to participate with you on this manuscript, and you keep those, that is very solid evidence that somebody was included from the very beginning and stuff like that. Because I don't want to go into this, but there have been some dirty squabbles as to whose name got included and whose didn't get included and things like that. And you can really sort of save yourself a lot of trouble by doing that. And then if, again, choose your journal immediately after that and then start writing it. And I think you made a very wonderful point, which is basically write your discussion first, and then you fashion the rest of the manuscript based on that. Because as a reviewer, one of the things that I find very difficult and biggest problem is the discussion is not written properly, or it's not up to date with all of the information and the references added in there. Sometimes the shortcomings are not listed totally. So those are the biggest issues. Of course, the annoying issues as a reviewer are spelling errors and poor grammar and all that stuff. And that usually is taken care of if you have a writer or a publication department. So with that, I'm going to stop. I do want to add one more thing. I agree with you that publishing negative study results are extremely important, but I also want to warn all our the audience that getting a journal to accept a negative study is actually really, really, really hard. They all do lip service to the fact that everything needs to be published, even negative results, but getting a negative study published is very difficult. I can speak from experience. It takes a lot of perseverance, but I agree with you. Negative study results belong in the published space because at the very least, it'll prevent somebody else from walking down that same path.
Thank you, Dr. Ravi. I have one question which I thought Professor Vikram could answer. They were asking about one of the, I think it's Dr. Sway Lack. May I know the role of authorship? Previously, our university encouraged it to be the first and corresponding author, but now changed to be the last. What should be the authorship?
No, authorship, now there are criteria based on that. And usually the first author and corresponding authors are important. Conventionally, the person who does the primary research, the primary investigator is the first author, and the person who supervises is classified as corresponding author. Remaining people come in between.
Okay. Over to
the
you.
advantage of corresponding, the advantage of corresponding authors is the corresponding author's ID only is then the publication. So naturally, the senior author gets to review the papers because based on that paper, editors will look at the ID of that paper and will receive the reviewer invites. That's the advantage of being a corresponding author. Advantage of being a first author is that person has done the primary research. So any particular research, suppose if it gets a lot of credit all across the world, it will go in the name of X et al. That's the advantage.
Back to you, Dr. Vidya.
there are a lot of questions about statistics as well, Dr. Vikram. How to get over the challenge of statistics?
I always advise everybody that better not to learn too much statistics. Take the help of a statistician. We're a clinician. We should know the principles of research. When we go and discuss with them, they also know that what exactly the person who's doing the research wants. Discuss with them and get the answers from them. I am not a believer of that you learn the softwares and other things and sample size calculation. Never have done that thing. Always told my students, go to them, this is what I want, this is my primary outcome. Tell me how much numbers I should cut. That's the way to do it. Basic principles of statistics, you have to understand. Definitely have to understand to talk to them. That's all.
I hope that answers two of the people who asked a question on statistics. If anyone else has any comments or questions, please raise your hand or unmute yourself and speak.
Can you ask Amit Ghosh to come in here?
Thank you, Pata. One of the reasons why I attend your series here is that there are very many people who can give a talk on the same topic. However, it's unique that you always select the right person or the best person in the country to give the talk. And Dr. Kate really broke this very complex topic into very manageable bits and beautifully presented it. And I wish when I was in JIPMER, I had this talk. Having said that, nothing is more distressing for me, because I work in an academic institution, to have a colleague of mine who's 65 years old and is retiring as an assistant professor, because most of the promotions are based on the publications. This person is an outstanding clinician, physician, had some practice experience, was also in charge of some things, but never got promoted because nobody taught them how to write a paper. And the trend in India and in US, I have so many colleagues who don't know how to write a paper. The trend is how to get into a PG, how to take all these quota courses and other courses, ace it, and join the practice. And all the brilliant minds, which are so good at anticipating and answering questions, cannot write a paper. Now, there is no answer for that. As Dr. Kate said, this is not a requirement, but clearly to be surrounded by people like Dr. Kate who would make it, that if you are a PG of this institution, your expectation is, like when I did my PG in PGI Chandigarh, that was the expectation, that at least 2 or 3 case reports, if not paper, and paper comes from research. And seeing what happened to the people who were writing 7 or 8 papers. One of my colleagues ended up as the president of the American Society of Nephrology. Another 6 months senior to me ended up as the president of the International Society of Nephrology. They were prolific right from get-go. It's never easy. It's like riding a bike. There's always a way of just learning it on your go or having an expert teach you. So having a mentor or a guru like Dr. Kate is so important. And as Ravi said, breaking out into these small bits on how to write the science of it. In fact, what I do is when I get a paper for review, I give it to my fellow. I said, why don't you review the paper and tell me your idea? Even PGs who learn how to review a case report or review a paper and having all those guidelines which are laid out, they also learn a lot. In fact, it's by rote memory we learn. See one, keep seeing, examine how case reports are written before you start writing one. But do not be hesitant, so scared that you cannot write. Now, I did part of my training in University of Minnesota, and there's a robust transplant group there which published a paper almost every day. And the way they did was that they had a writing group, but they had a medical writer. The content was gathered by the scientists, which is the clinicians, and then there were statisticians and robust publications. So by doing it several times, bits and pieces, they learned it. Of course, not all of them advanced, but some of them are world champions now. And the reason Dr. Kate's paper is recognized in US, because he's like an Olympic champion. If you want to compete in the international world, don't say that India is not good, that nobody will read your paper. You have to know what the standards are of international presentation. Neeraj Chopra proved it. He trained elsewhere. He trained in Germany. He knew all the styles. He did not sit down in Haryana and complain, nobody likes my javelin, nobody likes I can't speak English. So Dr. Kate's publications are reviewed at the highest level by people who are non-biased. There'll be some bias, but non-biased, who look at the content, who look at how it is written. And this does not happen overnight. So I would recommend not worrying about just this cannot happen and that cannot happen, and not degenerating some of the most brilliant careers I have seen as entering as residents in JIPMER and other institutions, and not writing a paper. You have got so much case presentation, snake venom, scorpion venom, this trial and that trial. Once you get into one kind of study, once you know how to write something, it leads to other things. The only way to fail is not start at all. Statistics, meta-analysis. I have had colleagues here who came with nothing, and now they're world beaters, because once they got better into it, they learn the language, they speak the language. It's like clinical exams. You get better and better and better. So if you are in a PG, this is for PGs and junior faculty member in an institution of national importance, and you are holding JIPMER as the institution you're proud of, as I am, please make yourself immortal, as somebody mentioned, by getting into this paper writing. You may not be a professor, but you will get, if you go to a non-academic institution, your papers will get you into leadership positions, into writing positions. You'll get you such position which just seeing patients will not get you. At the end of it, everybody buys a car and everybody drives it, but papers are what makes JIPMER immortal. And I'm glad that Dr. Kate, you were not there when we were training, I think, in the 70s and 80s.
Thank
and
you
you're
very much
probably
for
a
your kind words.
contemporary of mine. This is what is required. China is getting ahead because of a great content. Regardless of the English, they have writing groups, they're publishing in Lancet. Lancet has an office in China. I know the Lancet editor whose office is in China. And they're publishing, they led the COVID world, leading all the randomized trials, beautifully phrased studies. It is very doable, but it needs investment, leadership, not talk, write it. And rejection, love your rejections and absolutely embrace it, because the rejector, the reviewer actually is telling you how to make your paper better and go to the next level. So absolutely love rejections. I would stop here, but I like this trend. It's difficult. It's not easy, but so is becoming a doctor, and so is getting into JIPMER. You owe it to yourself to really go to the next level and make JIPMER famous. Thank you, Dr. Kate. It's an eye opener.
Thank you very much.
My son is in medical school, and I will have him listen to your talk. They listen to other people better than they listen to their dad. So I think it'll work better when he listens to your lecture.
Can I just add one more thing, Vidya, to Amit's point? I think Amit made a wonderful point about being committed to research. One of the things that, at least for me, when I was training, was that, clinical medicine was the be all and end all. And it was almost like a wedding planner. What they say about a wedding planner, you can't get married, so you plan a wedding. The same way, people who went into research were considered to be those that couldn't cut it in the clinical world. I think that mindset has to change, that you are not just a physician, you are a physician scientist. And the only way you prove the scientist part of you is through research and publication. And you can call it duality, but I think it's the same thing. You cannot be a physician without being a scientist.
Sabyasachi, go ahead. You can unmute yourself.
Yes, very good evening, everyone. And Sir Vikram Kate was an amazing talk, as usual. I am a big fan of his. And actually, his daughter is also doing a lot of good work and publishing a lot of good papers, following in your footsteps, sir. I just wanted to make a point. I just wanted to make a quick point. So I'm a novice in front of Sir, but I am the associate editor of the Indian Journal of Ophthalmology, and I see a lot of let's call it misdemeanor, or people don't pay attention much to publication ethics, and publish at any cost is something that even the novices should understand. Because we are seeing a lot of push nowadays. There may not be a lot of incentive, but then the younger generation now is definitely looking at making a name for themselves. You can't make a name enough by doing enough surgeries, but you can make a name by writing a lot of papers. So that trend is definitely coming in. But then I think people are doing sort of thinking about doing it at any cost. So I think publication ethics is something has to be at the front of everyone's minds. And as an editor, I see a lot of this, a lot of plagiarism and all of these. So a quick sort of comment was, please take care of publication ethics. Be true to yourself. Like Kate sir has already told this, but I thought I'll reiterate it. So thank you so much.
Thank you, madam. Thank you.
Sabyasachi, is in the coming weeks or months, we'll have another session totally dedicated to ethics of publication. Thank you for your comment. Radhakrishnan, you have anything to say?
It's always a pleasure to listen to Dr. Kate, and today's lecture is real wonderful. I think it will induce a lot of people into writing, and not just that. I think this will be one of those index presentations where any writer will always go back to and go through slide by slide. I think there's so many requests already in the chat box for this lecture. Is a very well crafted lecture, and Dr. Vikram Kate is not just a great writer and a great guide and mentor. Is a wonderful human being, and people who have interacted with him know all that, and is always ready to help anybody who was want to get into this medical writing. Thank you, sir, and thanks.
Thank you. It was a pleasure. Absolutely.
Murli has come with very valid points, and I think the contribution of Ravi and Amit was wonderful, and I think Marvelous Medicine is doing really marvelous in this area. The 51st lecture is real wonderful. Thank you, sir. Thanks, Vidya.
Thank you. Thank you very much. Thanks, Doctor.
Bye-bye. Good night, everyone.
We'll meet again next week with another episode of Marvelous Medicine. Thank you everyone for joining. We've had a record attendance, and I think we've had a lot of young audience. So we will keep you posted if all the notifications will be there in the Facebook group, Learning General Surgery, and also various WhatsApp groups that you belong to. So be sure to join us next week, because it will be on how to read a randomized control trial or a clinical trial. So it will be like a continuation of today's lecture. Do join in next week. Till then, take care and stay safe.